All right. So again, thank you all for joining us. My name is Jenny Byerly. For those that do not know me, I'm the clinical educator here at Inova Alexandria ED, as well as Springfield Healthplex. Just a couple of housekeeping items before we begin. If you could please put your name, your credentials, as well as your care site into the chat, that would be very helpful. We do have a number of folks joining us from other care sites, so that would help out. And then at the very end of the presentation, I will put a link to a survey evaluation. And then you do need to take that in order for us to be able to award one contact hour for this event. So just make sure that you stay on for the end so that you can get all the credit that you deserve. And so with that, I am going to go ahead and introduce Lauren Morin. She is a pharmacy resident that is going to be talking about the DKA updates and the algorithms. I saw her slides and she's got a great presentation planned. And we really do, she will say this too, but I'm going to say it as well. We really do want this to be interactive. There's lots of case scenarios and case studies so you guys can get practice with using the algorithms and using the protocols so that you all feel really comfortable and confident with this material. So with that, Lauren, I will hand it over to you.
Thanks for the introduction, Jenny. So I'll go ahead and share my slides and then we'll get it set up so we can start presenting. Let's see. Let me put this in presenter mode. Okay, which slides do you guys see? Can you see the presenter slides or do you see the regular slides?
It looks like we're seeing the regular slides.
Perfect. Okay, good. Thank you for that, Jenny. And then, like Jenny said too, this is a very interactive lecture. So I will be asking you guys to answer questions, A through B, A through D. If you are more comfortable changing your chat to just me being able to see your response, you're welcome to do so. I want to make sure that people are understanding the question. So if you're getting the question incorrect, I want to make sure I go over and iron out all of the details on that. So you guys can do that or go ahead and just respond to everyone for the presentation. But with that, I'll get started. If this will advance. There we go. Okay, so disclosures on the slide that has to be in here. Inova Nursing Professional Development is approved as a provider of nursing continuing professional development by the Virginia Nurses Association, an accredited approver by the American Nurses Credential Centers Commission on Accreditation. Criteria for successful completion includes attendance of the entire event and completion of an evaluation, like Jenny had mentioned. There are no relevant financial relationships with ineligible companies for those with the ability to control the content of this activity. So what we'll be talking about today is reviewing the management of diabetic ketoacidosis, recognizing key safety opportunities, and then applying the algorithms based on the glucose levels. So what is DKA? It's a serious acute complication of diabetes. Hyperglycemia symptoms are polyuria, polydipsia, so peeing a lot, having to drink a lot, weight loss, and neurological symptoms. So someone might come in lethargic, might have some focal signs, and obdentation. It's diagnosed when the glucose is greater than 250 milligrams per deciliter, patients having positive urine ketones, being the ketoacidosis, and then the anion gap, the acidosis part. So what is an anion gap? The anion gap is calculated with the sodium and potassium being subtracted, or subtracting the chloride and the bicarb to calculate the anion gap. This checks the acid-base balance of the blood, and too much acid in the blood is called acidosis. So in DKA, the anion gap of greater than 12 is what we're looking for. And then I also have HHS on this slide here, and those are more normal because you don't have the acidosis in HHS. And then bicarb is also a primary driver of this anion gap, so I wanted to make sure that was in there as well. So if you're going to have the high anion gap and you have a low bicarb, then that can cause the anion gap to increase. And then as the bicarb gets bigger, the anion gap can close. So there's this glucose point of care order, and I just want to review this a little bit with you guys. So you want to check the blood glucose levels every hour until the blood glucose is between 100 and 150 milligrams per deciliter for 4 hours. After that 4 hours, if the blood sugar remains in that range, then you can go to checking every 2 hours. However, if the blood glucose falls outside of that range, being over 150, then you want to return to checking the blood sugar every hour. So we'll go into our first question here. LF has the following blood glucose readings over the next 4 hours. Each hour, the blood sugar readings are 140, 145, 130, and then 132. What happens next? Go ahead and put your answer in the chat, please. Awesome. Thank you guys for participating in our first question here. Yes, B is the correct answer. So because they're staying in that range, they are below 150, we can go to checking every 2 hours. Here's our next question. So patient CC has the following blood glucose readings over the next 4 hours. Each hour, it's 140, 145, 146, and 152. What happens next? Awesome. Thanks for also participating in this one. A is the correct answer. So you want to continue every hour readings because that 152, although it was the last of the 4 hours, it did go out of range. So you want to go ahead and continue checking every hour. Next question. So BG has the following blood glucose readings over the next 4 hours, each reading being 140, 145, 146, and then 144. BG is then changed to every 2 hour glucose readings. BG's reading 2 hours later is 155. What happens next? Awesome. Guys got it right again. So yes, change to Q1 hour readings. Because the 155 went out of range, we go back to the beginning. Okay, so what is the mechanism of diabetic ketoacidosis? So it's a lack of insulin leading to an increased glucose levels. What factors cause DKA? So it might be caused from an infection, such as a pneumonia or a UTI. Could be from non-compliance, so patients not taking their insulin, or it could be from an acute major illness. So an MI, a stroke, sepsis, pancreatitis, and I guess, yes, sepsis is an infection as well. So the DKA treatment focus is going to be correcting electrolyte imbalances, correcting the dehydration, and then correcting the hyperglycemia and acidosis. And this is an important order too, and we'll get into that in a little bit more of the detail, but we'll be doing it in this order. So correcting electrolytes, then the dehydration, and then the hyperglycemia and acidosis. So with the electrolytes, we want to do potassium repletion if the potassium is less than 3.5. And with that, we want to give 40 milliequivalents IV. And then you would start the insulin infusion after the first hour of potassium infusion. So you want to make sure that they get enough potassium before you start the insulin. The next thing we'll do is correct the dehydration. So we'll give them a bolus of fluid followed by a continuous infusion. And then you can include potassium chloride in the continuous fluids if the potassium is less than 5 and the serum creatinine is less than 1.6. And then we'll correct the hyperglycemia and acidosis. So option 1, you can do the no bolus option, and that is 0.1 units per kilogram per hour. Or option 2 is doing a bolus plus the infusion at 0.1 units per kilogram bolus, followed by 0.1 units per kilogram per hour. And this is going to be more used in patients whose blood sugars are a little bit higher, so being above 600. So what are the protocols looking like? I know they're changing everything next week for you guys, and I think it looks a little bit cleaner. So we'll start to go through these now. So again, we want to correct the potassium first. So if the potassium is less than 3.5, you want to give the insulin infusion after the first hour of potassium. So that 3.5 is a key number to be looking at. We also want to consider the first hour being important as well to make sure they get enough potassium. You can do either of, the provider can order either of these options, doing a peripheral line or central line, depending on what the patient has. As far as the IV fluids go, this order looks just a little bit flip-flopped as I was kind of looking at it. So you give the bolus solution first. So you would do the plasmolate or the lactated ringers, depending on what the provider ordered. And then you would do, the provider would choose one of the options below. So if the potassium chloride, you would give potassium chloride 20 milliequivalents if the serum potassium is less than 5 and the serum creatinine is less than 1.6. If the serum sodium is greater than 140, after the boluses, you would want to do the half normal saline as an IV fluid. So this might look a little interesting too. And looking further into the orders, it looks like you would get your labs first when the patient came in, and then you wouldn't even look at the sodium level until 4 hours later. So if the serum sodium is greater than 140, after, like at the beginning, then after the boluses, you don't check again, but you give half normal saline. And please stop me if you guys have any questions. You're welcome to unmute yourself, ask questions, or put it in the chat. And I'll also take questions at the end. So why do we care so much about correcting the potassium? So insulin causes potassium to shift intracellularly with this pink arrow here. And therefore it can lower the serum potassium levels. Potassium is corrected first before the insulin to prevent hypokalemia, leading to possible cardiac arrhythmias. So for our next question, which potassium level are we going to correct before giving the insulin? Did you have a question, Jeannie? Okay, awesome. Thank you guys for answering. Yes, 3.1, because it is less than 3.5. Great work. Next question. How long are we going to infuse the potassium before we start the insulin infusion? Yay, great work, everybody. And then this is either the, this is going to be the insulin. So it doesn't matter if it's the bolus or the infusion. This is just before giving any insulin, we are going to be correcting the potassium. So here's what the new step 1 looks like. And you might be familiar with the orders themselves or the algorithm, but it just looks a little more clean and more organized in these new ones. So step 1 is the initial insulin bolus and the infusion rate. So again, like I had mentioned before, you can do the bolus with the infusion, or you can do no bolus and just give the infusion. And then again, you're checking the blood sugars every hour. And then if the blood glucose level is more than 600, you do want to send stat lab glucoses. So just a quick study as to maybe why the thought behind doing a bolus or not a bolus. So this study was called, is priming a dose of insulin necessary in a low dose insulin protocol for the treatment of diabetic ketoacidosis. So the purpose of this study was to assess the efficacy of insulin priming dose with a continuous infusion of insulin versus 2 continuous infusions without the priming dose. So this was a smaller study. There were 37 patients, and it was a prospective randomized design. Group A got 0.07 units per kilogram, followed by 0.07 units per kilogram per hour. Group B had no load and a 0.07 units per kilogram per hour. Group C, they called it a no load, but double infusion. So being 0.14 units per kilogram per hour. So the results, the hours to glucose control, it looks like it was better with group C. It took about 3.7 hours to get there. And then the hours to glucose recovery was about 10 hours in group C, again being our group C of the no bolus. And then the glucose, like the levels that the patients were having, the initial value, and then the estimated slope. In looking across these three, group A, which was the bolus followed by the infusion, had that steeper slope. So we can kind of think about this as maybe, causing patients more to drop their glucose levels. So maybe hypoglycemic in these patients might be a problem, or correcting the insulin too quickly. And then group C, it's not as steep of a slope. And then group B, overall, they didn't find that this one corrected the hypoglycemia as well. So that's why we don't do the no load and the 0.07 or 0.1 units per kilogram per hour. So not giving a bolus and increasing the drip rate can help with the safety profile by lowering the risk of hypoglycemia and results in a lower risk of quickly dropping the potassium level. So what does the pump look like? So I want to point out here, as you guys have all seen the screens, at this insulin pump, we want to look for the one that says 100 units per 100 milliliters. And then the dose, we also want to point out here, it's going to be in units per hour. And also, as I'm sure some of you may have seen, there's an insulin pump that might be units per kilogram per hour, but we want to make sure that we're not using that one and using the units per hour. In your MAR, it will look something like this, where you'll want to use that dose again in units per hour in that red box. And then, as you guys learned probably from your first training on this, you'll get that BPA that says to double check insulin infusion dosing units when charting for DKA HHS insulin infusion protocol. You want to make sure you change the units to units per hour when using insulin infusion algorithms. So the rate in units per hour is always available on your MAR. So we're going to go into another question here. I'll give you some time on this one. Which pump is the correct pump? Awesome. You guys are crushing it on these questions. Yes, so B is correct. Insulin 100 units per 100 milliliters, and then always use the units per hour insulin infusion pump. And then the rates, again, being in units per hour, is always available on the MAR. Great work. Okay, step 2. So subsequent insulin infusion titration. So hourly blood glucose changes is what we're going to be looking at. So if if there's a decrease by greater than 100 milligrams per deciliter every hour for 2 consecutive hours, you want to reduce the insulin infusion rate by 50%. If there's a decrease by 50 to 100 milligrams per deciliter, you can continue the current rate until the blood sugar is less than 250. If there's a decrease by less than 50 milligrams per deciliter for 2 hours, 2 consecutive hours, you want to make sure you call the provider for further instruction, and then consider regular insulin 0.1 to 0.14 units per kilogram IV once, so as a bolus. Next question. LG is an 84-year-old female presenting to the ED with a blood glucose reading of 527 and is diagnosed with DKA. She weighs 90.7 kilograms. She started on a continuous infusion of 0.14 units per kilogram per hour at 12.7 units per hour. After the first hour, her blood sugar decreases to 400, and then it decreases to 280. After the next hour, what is her next step? Okay. So yes, the answer is A, and it would be at 6.4 units per hour. So this one might have been a little tricky because we had the 527 up here and then the 400. So the difference between here is 127. And then an hour later, we went from 400 to 280. And so because the drop between these three from 527 to 400 to 280 was more than 100 each time, we fall in this top box, decreased by greater than 100 milligrams per deciliter per hour for 2 consecutive hours. We want to reduce the insulin infusion rate. Next one. TP is a 65-year-old male presenting to the ED with a blood glucose of 658 and is diagnosed with DKA. He weighs 73 kilograms and is started on a continuous infusion of 0.14 units per kilogram per hour at 10.2 units per hour. After the first hour, his blood sugar decreases to 638 and then 610 after the next hour. What is the next step for patient TP? Awesome, you guys got this one quickly. Yes, call the provider for further instructions and consider regular insulin 0.1 to 0.14 units per kilogram IV once. And this is because from the 658 in an hour, it drops to 638, so 20, and then dropping from 638 to 610, another drop less than 50 for that next hour. So if we're going to be considering doing this insulin bolus, the 0.1 to 0.14 units per kilogram IV once dose would be a recommendation of 7.3 to 10.2 units per hour IV bolus with the patient's weight. Next question. MD is a 23-year-old male presenting to the ED with a blood sugar of 489 and is diagnosed with DKA. He weighs 53 kilograms. He started on a continuous infusion of 0.14 units per kilogram per hour at 7.4 units per hour. After the first hour, his blood sugar is 420, and then it goes to 340 after the next hour. What is the next step for this patient? Awesome. Great work, everybody. So yes, continuing the current rate until the blood sugar is less than 250 because they're decreasing by 50 to 100 milligrams per deciliter every hour. So now we're going to get to everybody's favorite part, being these algorithms. So when the blood glucose is less than 250 with step 3, we will titrate the insulin infusion rate per the insulin infusion algorithms. So I've listed the algorithm below. The blood glucose every hour being less than 250 on initial insulin infusion rate. If this happens, we want to change the insulin rate to the respective rate on algorithm 2. So for most of the patients in the ED, we will be starting them on algorithm 2. And for most patients in general, they get started on algorithm 2. Then you want to make sure you call the provider for the order to add dextrose to the IV fluid. If the blood glucose is greater than or equal to 200 and has not decreased by 50 milligrams per deciliter in 2 hours, you want to move from algorithm 2 to algorithm 3. If the blood glucose is less than or equal to 70, you want to follow the hypoglycemia protocol, which on the steps, you guys will see it as the one right below, but we'll get to it in a minute. And then you want to move down one algorithm. So if you're on algorithm 2, you'll go to algorithm 1. If you're on algorithm 3, you'll go to algorithm 2. And then if you're on algorithm 1 and the blood glucose is less than or equal to 70 milligrams per deciliter, you'll hold the insulin infusion and let the provider know to discuss potential etiologies for the hypoglycemia. So we'll get into some more questions. Patient LG is an 84-year-old female on an insulin drip at 6.4 units per hour for her DKA. Her blood sugar drops from 280 to 127. What is the next step for this patient? Okay, I like this. We have lots of different answers. So just to review, if the blood glucose is less than 250, you would complete everything in this box. If the blood glucose is less than or equal to 70, you would complete everything in this box. So going to our answer, both A and B being answer selection D. So we would want to change the insulin rate to the respective rate on algorithm 2. And then we want to make sure we call the provider for an order to add dextrose to the IV and fluid. Moving up to algorithm 3 would happen if the blood sugar is greater than or equal to 200 and has not decreased by 50 in 2 hours. And then the patient never got below 70, so we don't have to worry about this box here. Next question. Oh, I'm sorry, not next question. So what about the anion gap closing? Because this is a question that was brought up to me when I talked about doing this. So what if the anion gap hasn't closed, but the glucose is below 200? You want to keep giving insulin. Now that might sound a little concerning because obviously we're concerned about hypoglycemia, but the gap will eventually close. But it's very important that we call in step 2, call the provider to for the order to add dextrose to the IV fluids. Now here's our question. SG was transitioned to algorithm 2 for the management of her DKA due to blood glucose levels of 240. The next hour, her blood glucose was 230. An hour later, her blood sugar drops to 220. What is the next step for SG? Okay, great work. Sarah, I love your enthusiasm there. Go to 3, yes. So we want to move up to algorithm 3. Next question. So we're moving up to algorithm 3 with patient SG. What is the new rate for the glucose level of 220? Okay, I like the variety of responses between B and C. So we're deciding between B and C. We've successfully said not A, not D, but we're moving up to algorithm 3. So yes, algorithm 2 is in this beautiful highlighter yellow, but we're going to be focusing on algorithm 3 because of the patient's blood sugar being 220 and needing to move up for this patient. So we're going to come down here to the 210 and to 239, and we're going to be selecting 6 units per hour, the answer choice C. Does anyone need me to clarify this a little more? Okay, we'll go to the next question. But again, if anybody has questions, please let me know. Patient JH, they're on algorithm 2, and his blood glucose drops to 64. What is the next step? Okay, I'm seeing some answer choice Ds in the chat. If I remind you that the patient is on algorithm 2 and the patient's blood glucose drops, does that change your answer? Okay, great work, everybody. Yes, answer A is the correct answer. So we would stop the insulin drip if the patient were on algorithm 1, because at that point we can't move down anymore. But because they're on algorithm 2, we can move down to algorithm 1 and then use the hypoglycemia protocol that I'll be reviewing with you in the next slide. Does anyone have any questions on this? Okay, let's talk about the hypoglycemia protocol. So when the blood glucose is less than or equal to 60, you can hold the insulin drip and give either 25 grams of dextrose 50% IV or 25 grams dextrose 10% IV. Then you'll want to repeat the blood glucose every 15 minutes for 4 hours and move to step 2. Step 2 is to resume hourly blood glucose levels when blood glucose is greater than 150 and restart the insulin infusion using the next lower algorithm to the left. So from 2 to 1 or 3 to 2. If the blood glucose is between 61 and 70, like our patient, we would hold the insulin drip, give 12.5 grams of dextrose 50% IV or 12.5 grams of dextrose 10% IV, and then repeat blood glucose every 30 minutes for times 2 and move to step 2. At that point, we would resume hourly blood glucose levels when blood glucose is greater than 150 and restart the insulin infusion using the next lower algorithm to the left. So another question that was brought to my attention was, hey, if we're going to be giving dextrose 50%, it's not on the current order. So then do I have to reach out to the provider and get that order? So no, with this new protocol, the dextrose 50% bolus is built into the order set. So you'll be able to pull it for the patient. So here's our question. For patient JH, what is the correct amount of dextrose to administer for a glucose of 64? Awesome. Great work, everybody. Yes, hold the insulin drip and give 12.5 grams of dextrose 50% IV. So we would be following this box. Step 4, transitioning the patient off of insulin when specified. When the anion gap is less than 12 and the patient's tolerating sips of water, that's a reason that we could transition them off the insulin infusion. You want to call the provider for them to assess if it's appropriate for them to transition off of the insulin infusion. When the basal insulin is ordered, being either glargine or NPH, you can discontinue the infusion of insulin and dextrose-containing fluids 2 hours after starting the basal insulin. You want to check the blood glucose level every hour for 2 hours after discontinuing an insulin infusion. So just a little tip, if you transition the patient off of insulin between midnight to 6 o'clock, patients might not be eating during this time, so it's best to maybe wait until the morning. So in conclusion, there are updates to the DKA HHS protocol for ANOVA. ED, DKA, and adult DKA HHS admission orders are now combined. Therefore, there's no need to reorder the insulin infusion protocol. It'll move with the patient when they go to the floor. You want to make sure you correct the potassium when it's less than 3.5 milliequivalents per liter before starting the insulin infusion. You want to make sure you have the correct pump settings. So insulin being 100 units per 100 milliliters. There's that BPA alert that will be a reminder to verify the dosing units for DKA HHS insulin infusion. Most patients will be starting on algorithm 2, so you don't have to worry too much between that algorithm on the one that you're going to be starting on. What questions do you guys have for me?
This is just an aside. Considering there's a shortage on D50 currently, how are we factoring that into the administering D50 for those who drop their glucose below 70?
That's a great question. I do have my preceptor on this call, Kristen, but we do want to make sure that we're not making our patients hypoglycemic. So we're going to make sure we're giving.
So I can jump in. And so that ongoing shortage that we have all been facing is why in the hypoglycemia treatment protocol that Lauren showed, you have a linked order for D10% or D50%. And so that allows the nurse to select the product that's actually stocked and available in the Omnicell. So right now we're struggling with D50, and so you know, whenever we can use D10, that's advantageous. You know, at prior points, we were also struggling to get enough of the D10. So, but basically this set allows that flexibility to choose whichever product you actually have available to you. And it gives the instructions for what the volume would need to be in order to ensure the patients, no matter what product is used, getting the appropriate and equivalent grams of dextrose.
Thank you very much.
I see a chat question here. What would be the rate for the dextrose? So these are the boluses. So it's not, I'm assuming, Trang, you're asking about the hypoglycemia dextrose. So they would just be the bolus of dextrose. And I'm sorry, over 15 minutes. It's in here, yes.
There you go. That's what I was just going to say. It'll be in the order in your mark.
Yeah. Or on this one, over 8 minutes. Yes. Thank you, Jenny. Thanks for the question.
Are there any other questions for Lauren, whether it be the algorithms or the protocol itself? Anything that needs to be clarified? Lauren and Kristen, this is going live, is it March 15th?
I believe so.
Yes, that sounds right.
Okay.
I put it in my calendar.
Okay.
Yes, it'll be live on the 15th.
Okay. So next Wednesday,
Yes.
coming soon.
Yes. And Jenny told me that she would send out the slides to everybody. So if you read through them and have questions, I'll go ahead and put my email on the slide deck as well, Jenny, and I can resend it to you, or if you want to add that, then you guys are more than welcome to email me any questions you have.
Yeah, that would be perfect. And then this has been recorded. And so what I'll do is I will send this out to our Alex team as well as our Mount Vernon team. And that way, Kathy, I know you're on the call. That way you can disseminate it to your staff as well. And we'll get the PowerPoint too. And I am going to put into
Thank you, Jenny.
yeah, absolutely. I'm going to put into the chat here the link to the survey. That way, as long as you take that evaluation survey, we can give you that contact hour. Do that right now. And let me share my screen. If it's easier, I also have a QR code. So let me just put that up there. Are you guys seeing that? The slide with the QR code. Okay. Yeah, so either way, you can do the QR code or there's a link in the chat, and then go ahead and fill that out. And yeah, let us know what you thought about the presentation. If there was questions remaining or anything like that, let us know how we can make presentations better in the future. And then also, if there are some educational topics, whether it be medication wise, protocol, equipment, anything like that, please let us know, because it's early in the year. So we have the whole year to, tackle education topics that you guys would like to see. We definitely want it to be helpful to you all at the bedside. So please let us know. And I'll keep the slide up there for a few extra minutes just to make sure everybody is able to do that survey. And so while we're waiting for that, I did want to thank Lauren again and Kristen for coming to us today and giving us this great information and explaining the protocol. So I think it was great information. It'll be very helpful for our staff, especially next Wednesday going live.
Yeah, thank you so much, Jenny, for coordinating everything and making this eligible for CE credit is awesome.
Absolutely happy to do it.
Yes, thank you. And thank you everyone for participating in my questions. I really appreciate it.
All right, with that, unless anybody still needs me to hold open the slide anymore, I think we will, and barring any other questions, I think we will go ahead and give you back 10 minutes of your time. All right, thank you everyone. Thank you for joining us. Have a great day.